it's an honor. And it's a double honor since the other honorees are really distinguished scientists. A Nobel laureate and a major contributor to cancer biology, especially cancer immunotherapy. And I'm doubly honored for that. Well, it's all research. I mean, if you're doing research on patients, investigating a new drug, looking at a new biomarker, versus working in a laboratory, you're still asking a question. And if you're asking a question in a scientific way, from which an answer might be useful, it's all science. So you can talk about basic science, you can talk about clinical science, it's all science. You're asking a scientific question. Sometimes negative, sometimes extremely positive. I call it the "look what I found" syndrome. But anyway, yes, you can be disappointed, and you can be pleased. It depends on how you react to the information that's forthcoming. The science of structuring the new drugs, called targeted agents, is such that you're going to be pleased more often than they were in the past. It depends on the psychology of the patient, but very often they're pleased, especially at the Dana-Farber, where we have a good reputation, I think, for care of patients, that they realize that if it's a randomized trial, that they can't be randomized to a negative drug, a negative part of the study. The federal government, the NIH, won't allow you to do it. The feds will certainly not allow you. No institutional review board will allow you to do a study where somebody gets a known inferior treatment. So you always randomize patients standard treatment versus the new treatment. Sometimes the new treatment doesn't do any better than standard treatment, and sometimes it's better. But the patient explain that ahead of time, and they sign informed consent. And informed consent means you've informed them and told them all about the expected side effects, if there are any, and they either agree or don't agree. Most of the time they agree. It's very exciting, since you remember the disease when it was more difficult to treat. I'm thinking recently the disease chronic lymphocytic leukemia. There are at least 2 brand new drugs that are changing the prospects for that disease without the toxicity of the old-time chemotherapeutic agents that we used to use, or still use really, but that we used for treating a disease. But now these new targeted agents are dramatic in their effect. So this is a disease whose, I think, survival is going to change radically. It's already changing in the disease multiple myeloma with the new drugs. It used to be the median survival was 3 years, now it's up to 9 years. And that's real progress. It's moving very quickly, I think. For example, those 2 drugs for chronic lymphocytic leukemia, the drugs for multiple myeloma, and now the CAR T cells, the modified, taking the patient's own T lymphocytes and genetically modifying them outside of the body, growing them up outside of the body, and then reinfusing them into the patient. The results are phenomenal in the diseases that they're being treated. Usually childhood leukemia and lymphoma, and the myeloma. And patients who are on the brink of dying, 6 weeks after they get the infusion, they're back to work. I mean, it is quite dramatic in some instances. Not every case, but certainly in many cases, it's the most gratifying thing you'll see, because you see these very sick patients who've failed bone marrow transplant and failed all kinds of chemotherapy, and get onto this, taking their own cells and then modifying them and reinfusing them into the patient so they don't reject them. and then causing these cells will go and hunt every tumor cell in that body and eliminate it, is quite dramatic. And then there are the new drugs that are called checkpoint inhibitors. We used to wonder how, if we had an immune system, how we allowed any cancer to develop in us. If they all begin from a single cell, why didn't we eliminate it? And I think Dr. Allison is one of them who's being on it today. But scientists have worked out that cancer cells, in order to survive, have to have something on their surface that protects them against the assault by T lymphocytes in the body. And the answer is there are these mechanisms. And the answer to that is there is a monoclonal antibody, a series of monoclonal antibodies that disrupt that bond, that bond that immobilizes the lymphocyte. And that bond is disrupted, and once that's disrupted, then the lymphocyte can go ahead and kill. And it does. And we've seen that especially in lymphoma, Hodgkin's lymphoma, at the Dana-Farber with a drug called nivolumab. And it's like releasing wild dogs. Suddenly the whole immune system goes after the tumor. And these patients had failed chemotherapy, failed transplant, failed everything. Had already about 5 lines of therapy, and suddenly the tumor disappears. I'm telling you, it's really, for those of us who've seen the worst of it in the past, it was very, very gratifying.